Okay. Okay, we're going to get underway. Can I ask you, those of you who are in the aisle there to take a seat? We'd like to have everyone try sitting in these two middle sections here. And I want to have Dr. Wild come up and we will get started. So we're going to need you to wrap up your conversations and take a seat at this time.
Can everyone hear me? So you guys initially met me when I was up on the stand here, and actually Tom Lloyd is going to be coming in as well. I think maybe, I don't know if he got lost or not, but he'll be coming in as well. But my name's Chris Weil. I'm at Washington University School of Medicine, and I care for patients with inclusion body myositis. I have an active research program studying both clinical as well as preclinical models of inclusion body myositis. We're interested in genetics of inclusion body myositis. We're interested in understanding how to even split patients with inclusion body myositis into different categories, because we think that there may be therapeutic responses that some patients would benefit from and other patients may not benefit from, and vice versa with other types of therapies. And so those are many of the questions that we're interested in, but I'm happy to answer questions about virtually anything. So why don't we just go ahead and get started? It looks like there's a question back there. I don't know, is there somebody walking around with microphones or? I guess I'm going to walk around then.
I've got a microphone right here,
Okay.
So just raise your hand if you have a question. Okay. You're closest.
Okay. I have IBM. I'm from California. I have IBM, had it for 10 years, and just in the last 2 months, I've noticed a lot of shortness of breath. Anytime I exert myself at all, which is not very often, but I have a shortness of breath. It takes a while. I've been on the nebulizer more in the last 2 months than I have in my lifetime.
Yeah, so the question is related to shortness of breath and inclusion body myositis, and that can absolutely happen in patients with inclusion body myositis. It's one of the things that we worry about later in the disease state. So we worry that patients will have respiratory difficulties. And I guess I would make two comments about respiratory difficulties. One is that
we need to have you stand closer to the podium.
All right, I'll stand up.
You're on TV.
So I guess I'd say, like I said, two comments about respiratory difficulties. One is that we should never assume that the respiratory problems that you're describing, so having some shortness of breath, whether it's whenever you're exerting yourself or just sitting there, we should never assume that it's from the inclusion body myositis. So the first thing we want to make sure of is that you don't have another lung problem that could potentially be treatable. So whether it's COPD, whether it's even an infection of some sort. So that's the first thing I would make sure of to address. And I guess the second comment would be if you do develop respiratory issues, that is something that is treatable in IBM, and that whenever we talk about breathing issues, we're not necessarily talking about putting a tube down somebody's throat. We're talking about assisting in ventilation, and often it's just assisting in ventilation at night whenever you're sleeping. And so I'm sure all of you know people that have BiPAP, which is for sleep apnea. It's the same type of setup, and what we know is that in patients with neuromuscular disease that have respiratory problems, that non-invasive, meaning just having the mask on at night, improves your quality of life during the day because you get better, more fitful sleep. In addition, you blow off more of the retained carbon dioxide that you maintain during the day. So that would be my two comments. It is something that could be related to the IBM. So that's the first step, absolutely. And so seeing your pulmonologist and making sure there's not something else going on.
Good morning, doctor. I have suddenly come across anecdotally a lot of several other IBM patients that have high liver enzymes, ALT and AST readings. Is that common for IBM patients to have that, even to the point of non-alcoholic fatty liver disease, or does it mimic that?
Yeah, so the question is whether the ALT and AST, and these are called transaminases, and these are secreted by predominantly by the liver. However, that's not actually true. So actually, muscle breakdown actually increases your ALT and AST. And so if you have an elevated CK, so a CK is a muscle enzyme, you often will have an elevated ALT and AST. And it's not uncommon, and I wouldn't be surprised if some people in this room had a blood test and it was shown that their ALT and AST was elevated, and their primary care doctor said, oh no, you've got liver disease, we need to image your liver. And in fact, it was coming from your muscle. And there are ways to distinguish that by doing another test, which is so it's another acronym, a GGT, and you can actually see that one's more specific for your liver. But I would be reluctant in a patient with an elevated muscle enzyme to make the assumption that you had liver disease as well. It's possible, but I would not make that clear connection. Do you want to, Tom? Here's Dr. Lloyd. So we actually have another microphone for Dr. Lloyd.
All right, dueling banjos.
Okay.
Oh, I'm sorry.
Yes.
I have two questions. So you just said that one thing that you're into is different therapeutics for perhaps different subcategories of IBM. Now, my understanding is there is no therapy for IBM. So are you talking about more symptomatic treatment, like this gentleman just mentioned on his respiratory problem? Or basic question, I mean, are we still looking that there's no treatment for IBM right now, which is what my neurologist said? And then a second question, if I may, just real quick. For the dysphagia, is it common or highly recommended practice to have a gastroenterologist do the full workup if you have the dysphagia? Or are the speech pathology swallowing tests all you really need, or does it just depend?
Okay, I'm going to answer the first question first about what I meant whenever I said I was thinking about how to classify different patients in order to understand treatment response. And so when I talk about that, I'm actually talking about future therapies. And the reason that's important, and I just want to give a scenario. So let's say that we did a clinical trial, and let's say the clinical trial was the bemigrumab trial, so the one that we talked about where we do the myostatin inhibitor. And let's say that that trial, whenever they did 300 patients, let's say that on average those 300 patients didn't meet their endpoint. But what we can do, or what researchers will do, is they'll do analyses to see if there are subsets of patients within that group that did respond. And so within that group, it doesn't mean that everyone didn't get better. It means on average, all those patients didn't get better. And are there patients that did get some benefit? And what's unique or similar about those patients? Maybe, and I'm just speculating, I have no idea. Maybe all those patients were female. I don't know. But maybe it's more complicated than that. Maybe all those patients had a genetic polymorphism that made them more susceptible to the therapy. Maybe there were patients that got worse on that therapy. Well, I want to know that because I want to start to understand different types of patients and doing something that we call personalized medicine, where I can say, you're going to respond to this drug along with prednisone, and you're not going to respond to that. And so basically, that's the idea. I'm intentionally making IBM more confusing and more complicated, but it's with good reason. Maybe I'll let Tom answer the dysphagia question.
Sure, yeah. So I would actually second that. as far as like the real future of therapy in myositis and really in all disease is really what we call personalized medicine. So all of us are different, and we know IBM is probably not just one disease. There are probably variants. And so understanding how our environmental history, how our genetic makeup, age, sex, et cetera, all these biological variables will in the future, hopefully near future, actually play a major role in guiding therapy. In terms of management of swallowing problems, so swallowing problems are quite common in inclusion body myositis. Usually the problem is actually narrowing of what's called the upper esophageal sphincter, which normally will open and close when you swallow. And so what we think happens is that over time the inflammation actually causes a lot of scar tissue. And so the actual sphincter is not able to open up properly. And so in any patients with swallowing problems or choking and inclusion body myositis, we recommend what's called a video fluoroscopic swallow study, which is normally done along with a speech therapist. And if the swallowing problem is caused by actually narrowing of this upper esophageal sphincter, a relatively simple and effective treatment is actually done by a gastroenterologist, an upper endoscopy, where what they do is actually place a fiber optic tube into the throat, and then actually pass a balloon into that and expand that upper esophageal sphincter. So it's a esophageal dilation. And in our experience, most patients benefit from that. Now, whether it's 3 months or a year or more, it's extremely variable in terms of how long the benefit lasts.
As a tag on to that, because I had experienced last summer dysphagia, my speech therapist said that it was due to weakness at the base of my tongue, because the muscles there were not strong enough to open up that sphincter, and so she worked with me on building up those muscles through a series of exercises, and also using something called Vital Stim. Are you familiar with Vital Stim?
Yes.
And so I think that's just another solution that's pretty non-invasive that
Right.
might be helpful.
Good morning. Is there any evidence with IBM patients that they get extraordinarily hot frequently, or is my wife just hot?
I can't say that I've heard that complaint. Yeah, I can't say I've heard that complaint. I don't know about.
No, yeah. You live in Miami? Okay, well, yeah, maybe that's the problem.
Hello. I just don't know if this is related. 6 years ago, I had an episode with autoimmune hepatitis. Was given a regimen of steroids over a course of time. All the levels leveled out and monitored every year, so I haven't had any issues or any elevated levels since then. 3 weeks ago, after some signs coming up, I got my biopsy back and I have IBM. Is there any relationship between the autoimmune hepatitis and the IBM diagnosis that I have now gotten.
So I guess I would ask a couple of questions. So the autoimmune hepatitis was diagnosed. How was that diagnosed?
I had a biopsy done.
Of
at
the liver?
Rush. Just recently, 3 weeks ago, I got my results.
Of the liver?
Oh, I'm sorry. The liver was done at Northwestern, and I can't even remember now what they did. But that it definitely was autoimmune hepatitis at the time. It was attacking my liver.
Okay.
And so the elevation levels were really high at the time. The steroids dropped it all down. And since then, for 6 years, I've been monitoring, and it's been fine.
Yeah, so so there's clearly associations with other autoimmune disorders, as we talked about with the panel, Sjogren's syndrome being one of them. There are unclear reasons. I think that there are genetic components in patients with inclusion body myositis that leave them susceptible to a whole variety of different autoimmune disorders, things like lupus and other connective tissue disorders. So while there's not a clear connection that I know of between autoimmune hepatitis, it would not surprise me that a patient with IBM or a patient who'd had some other autoimmune disorder may be at risk for someday developing IBM. Now, whenever we're talking about this, we're talking about you. We're not talking about the population of everybody. So I would not run out and make an assumption that if somebody got autoimmune hepatitis, they're going to get IBM. I'd make the assumption that in you, because I know now, that if you got autoimmune hepatitis, you may also be susceptible to IBM.
One issue that not a lot of people are talking about is the use of marijuana. Now that it's legal in many states, some of us have been experimenting on our own, and it was mentioned in the first session, and I commented on that. And since in this conference, many people have come to me and said they are too. If you get the right kind, it does produce energy that enables me, I'll vacuum the whole house or whatever. It's also, I think, very effective with, I don't know how many of you deal with a little bit of depression, and but it's helpful in several different ways. And I'm wondering if there's any research being done with regard to myositis and marijuana.
So I get asked these questions a lot. I'm actually in Missouri. Missouri's not a medical marijuana state, but I do get asked that question a lot. You know, you were very clear in what the medical marijuana was doing for you. You were very clear that it gave you more energy, that it helped with depression, and I think that is awesome. That's fantastic. I don't think there's any evidence that medical marijuana can treat the underlying disease, but I would also suggest that perhaps other people can get the same benefits that you're describing in other ways. So I guess I would not want to say that the benefits that you experience of feeling more energy, that medical marijuana would be the only way of achieving that. If that works for you, I think that is fantastic, and that's fantastic. You're not making your disease worse. You're not doing anything to make the disease worse. So I guess I would think about it in that way. There's no clear trials on medical marijuana and myositis that I know of.
Right, and what I would add, though, is that actually exercise. So we often don't think of exercise as a treatment or as a medicine, but it's really becoming clear that not only exercise is, not only is it incredibly helpful for your muscles and your cardiovascular health, but very common symptoms associated with myositis, that we've been talking about. So fatigue and depression, a lot of those other symptoms exercise has over and over again shown in many trials to be effective.
In the back.
I just want to second what the gentleman up there said. I'm having very positive results from medical marijuana myself. My question is,
Can I interrupt? Can you? So I often hear this makes the medical marijuana helps. Tell me exactly what it helps with. What symptom? Because I think that's important. Because if you guys, let's think that we're going to design a clinical trial. Let's just do it right here, okay?
Yeah.
We're going to do a clinical trial, okay, on medical marijuana. Well, I can't do a clinical trial that just says, I think I like it. It makes me feel better. I want to know, exactly. So I'm not picking on you at all.
No,
I'm just saying,
I'm fine
just
with
help
it.
me understand.
Yeah. First of all, you have to understand that when you go into these medical marijuana places, they have a whole array of type. So you go in and they try and help as much as possible. They're very, very helpful. I go in and I say, okay, anxiety, pain. Those are my two big things. And my pain is very cyclical. It will come on and last for a few months, and then it goes away. But those few months are hell. So I know that I can either ingest. I don't really care for smoking much because it hurts my throat. But the pain goes away faster if I smoke it. Also, you can get CBD, I think it is, which is less of a high. And I'm not really interested in the high unless I'm really feeling bad. But it mellows things out. It just calms things down. You can function on it, you can work on it, you can, and I'm really lightweight. I can take maybe 1 or 2 puffs and I'm done. But it's been very helpful for me. And I was very skeptical, to tell you the truth, when I first started it. It took me a long, long, long time before I tried it. Is that helpful?
Absolutely. Thank you.
Okay. My question is about swallowing. So I've had the sleeve, and it lasted for about 5 months. So it was pretty good for 5 months. It wasn't like a miracle, but it worked pretty well. And now I'm going to go in for Botox because I'm considering surgery. And I'm wondering if that's extreme or if that's really isn't necessary, or am I jumping into something intense before I need to, or meaning the surgery?
Right. So when you say surgery, are you referring to what's called a cricopharyngeal
Yes.
myotomy?
Yes.
Right. So honestly, the vast majority of our IBM patients are able to improve swallowing with a combination of speech therapy, esophageal dilation, and other treatments, for example, Botox. And we will rarely recommend a cricopharyngeal myotomy. Now, part of that is our own sort of center experience. So it's a fairly involved surgery, and the risks are significant. But as with any surgery, the risks versus benefits actually depend an awful lot on the surgeon. So if I knew an ENT surgeon that I thought was, extremely good at performing that procedure, I may very well, recommend it. But the only patients that I've seen had it done, and my N is maybe 4. I had 1 with a severe complication, and then 3 who really did not have a lot of benefit. So I don't know what your experience is.
I think it absolutely center dependent. I am think very cautiously about using Botox unless it's being done by an ENT that has experience with dysphagia in patients with neuromuscular disorders, and so we do indeed have that. But I would be reluctant to have a community ENT who doesn't understand or appreciate it. I don't want to say doesn't understand, because that's not a fair statement. Doesn't appreciate some of the nuances. So,
in relation to the antibody that's relates to IBM, if you're tested for it and you have it or you don't have it, what is the significance?
yeah, so I can. Both of us have great experience with this antibody. So this antibody is called NTC51A. It was an antibody that was identified by 2 independent groups about 5 years ago. It was an antibody that's present depending on the lab and depending upon the report. It has a sensitivity of about between 40 and 60%. At WashU, where we do the test in our lab, we think the sensitivity is around 70%. In other labs, it's reported at around 40%. I don't know what Andy says.
Well, so we send it out usually through a commercial lab.
Okay.
RDL is
and they
the
quote
main lab
much
we
lower
use.
than that.
Probably.
Yeah.
Yeah.
So that doesn't mean that my lab's right and the other lab's wrong. It just is a different lab test. So to get back to your more important question was, what does it mean if you're anti-NTC51A positive or anti-NTC51A negative? And so there's been a couple of studies more recently that suggest that patients that are antibody positive may have a more severe onset of disease. And whenever we're talking about more severe onset, I'm not saying that they get worse dramatically quickly, but on average, those patients have more trouble with swallowing, and they do a little bit worse over time in looking at them. Whereas the ones that don't have the antibodies seem to progress a little bit more slowly. So that's what it would mean for the patient. What does it mean for me and for a clinical trial? Well, I just said that I want to do a homogeneous clinical trial, and so it might be very important if I had a clinical trial and I didn't mix the right patients together. So if I had one trial that had all the NTC51A in the placebo arm, and I had all the NTC51A negative in the treatment arm, well, now my drug doesn't look like it works very well because I've stacked the deck. So whenever we were talking, and the other thing about the NTC51A antibody is that it may be one of those personalized medicine aspects that would dictate someday that if you have NTC51A positive antibodies, that you would respond to a certain therapy, where if you have don't have it, you might respond to another therapy. But on a patient level currently, I'm not sure it means that much. I don't know what you tell your patients.
Yeah, right. So we looked at a number of IBM patients, right around 100, if I remember correctly, at those that were either antibody positive or negative. And in our actual cohort, the way we did our test, we actually did not see a difference in terms of rate of progression. Now, so it may be different in different actual patient populations, or it may vary depending on exactly how the test is done. So my own feeling about the antibody test is that if I know a patient has inclusion body myositis based on their history, exam, and muscle biopsy, I will essentially never order that test. If it's a patient that I think might have IBM, but I'm not 100% sure, and I want to order this antibody test to help increase my certainty, if I do that and the antibody test comes back negative, even if I send it to WashU or Steve Greenberg and this antibody is tested a number of different ways, if it's negative, it absolutely in no ways influences my thought process. So a negative test for this antibody really is not helpful at all. If it's positive, in my own view, more work needs to be done in terms of really finding out what that means.
So we were waiting for us to disagree on something. So I advocate ordering it on every patient. We do it in our own lab. I advocate ordering on every patient just because, just from a personal research, just so we have that data, I think it's important to know because we don't know the answer. And so I advocate everyone getting it ordered, and I would advocate even going back home and saying, hey, Dr. Lloyd, will you please order that antibody on me?
Well, so all of our IBM patients, we encourage them to enroll in a research study, in which case we collect DNA and serum. And absolutely, from a research perspective, that is one of the things that we're interested in.
Over here. Thanks for being here. I'm curious about the significance of sequential CKs and disease progression on IBM.
Right, great question. Unfortunately, a lot of rheumatologists are taught that really what you're treating in myositis are lab values, the actual CK value. While CK is extremely helpful in polymyositis and dermatomyositis in terms of measuring the amount of muscle breakdown, my own opinion is that it's really really unhelpful in terms of following patients with inclusion body myositis. Now, that said, I'll qualify that. So early on in disease, if a CK value is extremely high, so let's say 5,000 or more, it makes me wonder, could they have something else? Could they have an overlap disease with something else like polymyositis or muscular dystrophy? So certainly it is helpful in the initial evaluation. In terms of following CK level, however, a number of studies have shown that with prednisone, as well as other immunosuppressive therapies, prednisone will, in most patients, actually drop your CK level. In some cases, it'll bring it down to normal. But study after study has shown that that normalizing CK does not lead to improvement in muscle strength. And in fact, there are studies that long-term treatment with prednisone actually makes patients do worse. So in that respect, I don't think CK is a good measure of treatment response. And the other thing I will say is CK levels are higher the more muscle you have, right? So really strong bodybuilders will often have abnormally elevated CKs because they have a lot of muscle. And in IBM, as the disease progresses, often you will see a lowering of CK. And as you all know, when IBM progresses, the muscle disease isn't getting better, and we think that the loss of CK is probably due to loss of muscle and maybe also a gradual reduction in inflammation in muscle over time.
I agree. I check it once, and that's about it. If someone all of a sudden gets much worse, I might check it again, but I don't follow it.
I just want to thank you both for being here, and I'm very excited because you both are much younger than I am and probably most everybody in the room. I'm a medical oncologist at Yale, and I've been in practice for over 30 years, and have been recently diagnosed with myositis, though I'm not sure I'm in the right room because everybody I see tells me I have a different kind. And I think that the points that I made in one of the smaller groups that I hope to share with everyone is that I have been considered a good diagnostician among my clinician friends for years, yet I've been walking around with an unexplained elevated CPK for 9 or 10 years, unexplained arthralgias, unexplained fatigue, and was seen by rheumatologists and everything, and basically, I don't know, I thought it was hypochondriacal or just getting old. So I think that it is very clear to me, having been in practice for a long time, that I knew nothing about myositis until I became ill and I started reading about it, and I would say that even most of my very well qualified internal medicine colleagues know very, very little about it. Having said that, very few rheumatologists in general practice appear to have any appreciation for the advancement that's been made by you and your colleagues in recent years. When I started looking at this, I started thinking about, gee, how do we treat breast cancer in 1985, or how do we treat lymphoma in 1985, and how backward our treatment of breast cancer or lymphoma to me seems nowadays, given personalized medicine that we're doing and how much better the pathologists are at looking at things and deciding what specific kind of a disease you have and what's best for your kind of a disease. Getting back to a specific question, I had a long history of very slowly progressive rising CPK, had some cardiac issues in the interval, and I think one thing that's interesting to learn is there are a lot of medicines that make your muscles work worse, and there are a lot of medicines that might make them work better that you don't even realize. So when I ended up having some heart rhythm problems and they put me on a heart medicine, all of a sudden I couldn't walk up a slight incline. I mean, I never had trouble walking before, but just on a tiny dose of a heart medicine, I got much, 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 much worse. By the same token, when they did some kind of a PET scan on me and they gave me some kind of chemical, and I thought I was going to stop breathing, the technician says, oh, you need a cup of coffee, caffeine helps. So without my talking too much, I just want to get to my question. When you go and you keep getting different answers from different people about your pathology, the significance of your low positive antibody titers, I would say for patients, number one, continue to advocate for yourself, and number two, do you have any real advice for where you go when you've gone for your first opinion and your second opinion and everyone's different?
Right. Have you already been seen by a center that's affiliated with the Team A, or have a medical advisory board member?
No, PATH has been reviewed there, though.
Okay, yeah.
I'm planning on it very soon.
Right. So I'd recommend that.
So you bring up a great point. So if you go to different doctors, you might get different opinions, and that can probably be very frustrating. And I appreciate that. I think going to a specialized center, when a patient comes to see me, my goal is not necessarily to always take on the care of that patient as much as to help clarify some things, and then convey that to their community physician. So, so often it's just a single visit for somebody to review things and go over things, discuss with things. Your primary physician should not get upset if you say, hey, did you order, myositis-specific antibodies? Because I went to a meeting and they were talking about myositis-specific antibodies. Your physician shouldn't be upset about that. He may say, you know what, I don't think it's relevant for you, and this is why, and that's okay. Or he may say, I've never heard of them, maybe I'll order them. So I think, I think it's as you mentioned, it's hard for physicians. If you were to ask me about some other area of neurology, I might not be as up to date. I'm very up to date on this one small area, and so we try to work together.
In the back.
Can I go? What is the order of, should I have the video fluoroscopy before the endoscopy? Because right now my doctor has them scheduled in reverse. Which one do you have first?
I guess I would ask, first off, what the problem is.
Swallowing.
And swallowing but
the food feels like it gets stuck in my throat when I swallow, and so I'm like constantly.
So they're both diagnostic tests. So I guess I would put it into perspective. I guess that's how I would say. They're both diagnostic tests. Neither of them are doing a therapeutic intervention. So is it wrong to get both of them? I'm not your treating physician. I'm not sure there is a right answer of should you get one first and one the other. It would depend on the patient, but I guess I wouldn't worry that much about what order is happening, because it's just getting more information.
So my only reason for usually recommending having a video swallow study first is that if it does show narrowing of the upper esophageal sphincter, which is not always necessarily easy to make a diagnosis in endoscopy. But if it shows this narrowing, then actually at the same time that a diagnostic endoscopy is done, a esophageal dilation is often able to be performed.
Okay, my question is, going back to the antibodies, this is like antibody 101, I guess, but are antibodies something you're born with that are in your body, or are they formed as a reaction to fighting the disease, like IBM?
Yeah, so maybe we'll start with antibodies 101. That's fine. So whenever we talk about antibodies, antibodies are what attack foreign things, so viruses or bacteria. So if I'm exposed to chickenpox, I have antibodies that are directed at chickenpox, so that if I get exposed to chickenpox again, I don't get I don't get chickenpox. And so that's what antibodies are. So they're always floating around in our body. But I had to get exposed to chickenpox to make that antibody. So I wasn't born with that antibody. Mm-hmm. I was born with the ability to create an antibody. Okay?
Yeah.
So now let's talk about a different type of antibody, which are these autoimmune antibodies, which is the ones that we're talking about with the NTC51A, but also talking about with the other myositises. And so those are antibodies that I think we're not entirely certain whether and particularly NTC51A, that's almost in a different category. But most autoimmune antibodies, I would suggest, it's possible you're born with them, or they develop because you're exposed to some environmental insult or something, and then they start potentially wreaking havoc. But I guess the way I think about the autoantibodies, I don't think of them as a cause and effect. So I don't think that, so you might say, well, I've got this antibody, let's just get rid of it, and that'll solve the problem. And I don't think that's entirely clear for this type of antibody. That's true for some other autoimmune disorders, but not necessarily for some of the myositises. And I don't think I explained that very well, so I'm going to let Tom.
No. No, you did great. Actually, that was a great explanation, I would say. In NT5C1A, it's really unclear whether the antibody itself actually plays any role in worsening disease. So usually we think of it as a actual marker. So it's possible this antibody is actually generated in response to actual muscle breakdown. And so even though there is some research suggesting that maybe this antibody is bad, the vast majority of evidence really is unclear as to whether it's playing any role in propagating disease.
I got one other quick question regarding exercise. I'm 17 years into this IBM and I'm wheelchair bound. Will exercise help me at this point? Is it too late for me, or is any exercise at any point along the line good for you to try and retain whatever mobility you have?
Yeah, it's a phenomenal question, and I think that exercise in chronic neuromuscular diseases is understudied. What I can say, and I say this with caveats because I don't know for sure in late stage inclusion body myositis, but I do know that patients with inclusion body myositis who do exercise can regain some strength. So that's an important aspect to me. So it may sound kind of not that important, but what it says is that patients with inclusion body myositis can get more muscle. So that's an important thing to know, that you can get more muscle. It's not as if it's just going away. You can build back more muscle. Whether somebody, when I think of exercise, I think of what can you do and what can you do safely. I think of there are studies out there for other muscle diseases that are putting patients in assistive devices that remove some gravity so that they can do exercise. So you can imagine an Ironman suit type of thing, and so there are studies out there that are putting patients into scaffold type devices where they can move their muscles against gravity to see if they will improve muscle strength. But it's not being done in IBM. I think it's a really important question. It's one of the #1 questions that all IBM patients ask, which is, should I exercise? What should I do? And will it make me stronger?
I am from Missouri, and my husband was diagnosed in 2014. He started having symptoms in 2008. We went to many doctors, many neurologists in Missouri. I'm sorry I missed you. My question is this, and you answered one. The IBM had overtaken him, and he was bedridden, but he was still taking exercise. The pain in his back was extreme. How can you tell a person to exercise then? My question to you is, I didn't feel that the IVIG treatment that he was receiving was doing him any good. We did continue taking it. However, the best treatment that he did have is one that I recommended to the doctor or the neurologist, was for him to get testosterone shots because he didn't have testosterone, because he didn't have any muscle. One of the problems also, he had had a kidney and a liver transplant. He had had 2. He was hepatitis C, so the prednisone had to be monitored. But my question is about the testosterone mainly. He felt wonderful when he received weekly injections. I've tried to find out if there was any research on that, and I would like for you to answer that for me, please. Are there any pros and cons against getting testosterone shots? Thank you.
Yeah, there is one study actually using a related anabolic steroid, oxandrolone, and it was a small study that suggests perhaps some improvement in terms of muscle strength. The major sort of risks of either oxandrolone or testosterone and other hormones is side effects, right? So in particular with oxandrolone and testosterone, it often will cause problems with the liver. It can cause problems with cholesterol. So in most patients, it'll actually raise your bad cholesterol and lower your good cholesterol. So it is something that I think, so I would recommend certainly anyone with any degree of deficiency of testosterone to have that treated. But in terms of supplementation, I think that's more on a case-by-case basis, and really depends on what other medical conditions they have.
Right here. Do you know if there's any link between IBM and somebody being diagnosed with hypercalcium levels? Hypercalcemia. Calcemia. Thank you.
I don't know of any
No.
association.
Not that
Thank
I'm
you.
aware of.
Okay, I'm going over here. Go ahead.
As we get older, we start to see more and more different array of doctors. And I became quite aware a number of years ago that most of them understandably don't have any exposure to IBM patients. I find, though, they write prescriptions to treat whatever malady I'm coming in for. Again, I understand that. But as I read some of the effects of some of those prescriptions, muscle weakness, protonics causing the bones to weaken, recently given testosterone for a viral issue. And I'm confronted then with thinking, I'm dealing with a doctor that doesn't understand my condition. They're writing a prescription. Does that have a deleterious effect on my disease? And I don't quite know how to address that. It's a conundrum that I face all the time now as I get older, and I see different doctors out there for different things. So let me just stop editorializing and just ask you what your thoughts are and how or if we should be concerned about that, and if so, how do we confront it?
Yeah, that's a big problem. I agree. We call it polypharmacy, which means that patients are on more medications than they need to be on. I think that when I see a patient, I look at their medication list and I go through each medication. I say, why are you taking that? And sometimes they don't even know why they're taking it. Or I'll say, why are you taking that? And they'll say, it's for this. And I said, well, is that bothering you? And they're like, no. Or you say, can you take the medication and say, for example, I'll often ask, well, have you ever missed a dose of this medication? And they'll say, yeah. And I'm like, did anything happen? And they'll say, well, no. And so I think always thinking about trimming down your medicine list is important. So you said protonics, is that what? Yeah. So for gastroesophageal reflux. Yeah, for reflux. So if that's a big problem, you should absolutely be on something to help with it. And if it's got a little bit of side effect, perhaps in making your muscle disease worse, you need to weigh the risks and benefits. There is no free medication out there that doesn't have a risk. And so I think really just thinking and going through, you know, once a year with your primary care doctor and just saying, well, why am I on that? And is that, do I really need to continue to take that? We talked about statins. So statins is a great example. Statins, I mean, they're really good for you. I mean, they're really, I mean, there is no question out there that statins reduce cardiac events, reduce stroke, and there's no doubt out there that statins save people's lives. So whenever a patient with a neuromuscular condition comes to me and says, I don't want to be on statin because it's gonna hurt my muscles, I say, well, I don't really know if it's gonna hurt your muscles, but I do know that it might reduce your risk of heart attack. So I think it's really just balancing benefits and risks, and I encourage patients to really be empowered. Like, knowing why you're on a medication, what that medication is doing, and what you should expect from taking that medication. Should you expect to feel better on that medication? Then you better feel better on that medication if that's the expectation. So I guess that's the way I think about it. It's more of a philosophical answer for you.
Yeah, so I'd second all those comments. One other point regarding statins. Actually, statins do have anti-inflammatory properties, and in fact, statins were actually studied in inclusion body myositis. Now, it actually didn't show an improvement in muscle strength, but also it showed that actually statins are safe. And so if it were me or a family member who had any risks of cardiovascular disease in which their internist recommended actually taking a statin, I would absolutely recommend it. And it's also important actually to know that all statins are not equal in terms of risks of having muscle side effects. And in fact, some of them have very low risks of muscle problems. So exactly like Chris said, with any medicine, it's a matter of weighing risks and benefits. And one other comment I would make is that in any clinical trial, what happens is individual patients are asked a long list of questions, like, do you have abdominal pain, do you have headache, do you feel weak, right? So if you look at side effects of almost any medicine that's out there, it'll have weakness as a potential side effect. So it's listed even if weakness was also a symptom on placebo. So it's definitely worth actually looking to see, okay, what's the evidence that it actually causes weakness? Is there really a significant potential of worsening muscle disease in studies relative to individuals on placebo?
Doctors, I just wanted to point out this session is scheduled from 11 to 12. We're coming up right at 12 o'clock right now. The next scheduled event is lunch at 12:30. And I'm going to leave it to you if you want to take a couple more questions and go over. But this is your session, and so we've got some more questions lined up here for you. And
we're happy to, yeah.
Okay, well, thank you. Well, we're going to start right here.
We're supposed to be at 12:15.
Yeah, my question is, what's the progress on creating an effective model to study this disease in terms of looking the effect of antibodies? How far do you think we are along in that research?
So I'm going to let Tom answer. He's got a very interesting model that he presented yesterday. So,
well, why don't I start with actually Chris's model, which is actually a mouse model of inherited IBM, which it's caused by actually VCP. Now, there's a question as to whether, in fact, in some cases, in patients with VCP, might actually develop what looks exactly like sporadic inclusion body myositis. And that is an active area of investigation, but so the VCP model was used actually as the preclinical model in justifying moving forward with arimoclomol, for example. So on the one hand, really studying models like VCP and understanding better how these inclusions form, how they lead to muscle degeneration is extremely valuable. So our attempt at making a better model of inclusion body myositis is actually taking IBM muscle biopsies and implanting them into immunodeficient mice. And what we're seeing, it's early, but the muscle will regrow. So one's own human muscle cells will regrow, but the inflammation that was in the muscle actually persists. And so now what we're trying to do is, number one, inhibit the inflammation in the muscle in the xenograft model. And number two, actually try some of these newer treatments, arimoclomol, myostatin inhibitors, et cetera, to see if we can actually improve the muscle regeneration. So I'm optimistic that because we're actually using IBM patient muscle tissue, that we can really understand what's happening in this really uniquely human disease.
My question will be very quick. It's about dilation of the throat. I have had about 5 endoscopies, and I'm wondering if there's any threat or negative result of continuing this way. I have one about every 10 months.
Are you talking about the stretching?
The stretching, yes.
I don't think there's any bad.
I'm aware that it does cause scar tissue. Does it not?
I don't think there's any. It's treating a symptom, and so I don't think it's.
Okay, thank you very much.
Right here.
I want to thank you all for being here, and I appreciate your passion, and I will be praying for you that you'll find something for us here. This is my first time here, and I came here looking for hope. I'm going away with hope that you all are getting there, and I'm going home saying, okay, I've got to exercise, I'm going to take the supplements from the dietitian, I'm going to go anti-inflammatory diet, I'm going to continue my deep tissue massage, I'm going to look into speech therapy. Is there anything I'm missing? Please tell me before I go back to Tulsa, Oklahoma, where nobody knows anything about it.
I mean, the fact that you're here is a huge is a huge thing that you're able to come here, and so I think I hope that you guys are all able to support each other, and you were able to find support from other people as well. I think you're doing everything right. I think getting exercise, working on wellness, working on well-being, working on feeling good, praying like you just said, I think those are absolutely some of the most wonderful medicine out there. And I guess I can assure you that we are looking, and that there have been more clinical trials in inclusion body myositis in the last 3 to 4 years than there ever has been. And there have been larger trials with inclusion body myositis, and there have been more novel therapeutics being pushed and looking at different directions. So, I think there is a lot of reason to be hopeful right now. This is a disease that, that progresses slowly. And I think, many people think they're running out of time, but I don't believe that's the case. And so, my commitment to you is that I think there is hope, and I think that there is lots of exciting areas of research that are moving ahead, not just from Tom and I, but from many others.
Okay, I have a question over here. Just two real quick questions. I had a participant ask me this morning, how many appointments should you have, or the frequency of the interval of appointments with your neurologist? Some see him every 3 months, some 6 months, some 1 year, some don't even see him at all anymore since there isn't a cure or a follow-up. So I'm bringing that to you.
Yeah, I don't know if there's a standard of care. So mine is usually a conversation. My goal so diagnosis is one thing. So figuring out a diagnosis. Once we've established a diagnosis, my goal is to make sure that your disease is progressing in the way that I think it should progress, and that nothing new is happening that makes me think, you know what, maybe there's something else going on. So I think to do that, I see my patients every 6 months.
Okay.
Now, some patients, it's difficult for them to come and see me, and that's okay if they want to see me in a year. Some patients come and see me for a year and realize I'm not doing anything and decide they don't want to come anymore, and that's totally cool also. That doesn't bother me. So I think there's no right answer. I'd be curious what the Myositis Center does, how often.
Yeah, so what I would say is that if it's a typical, very slowly progressive inclusion body myositis patient, on average, usually we'll follow them on a annual basis. And the reason why I like to encourage patients to actually follow up is even though we're not necessarily prescribing anything new, as the disease progresses, there are lots of other supportive measures we can help with. So anything from ankle foot orthosis for foot drop and gait to having you plugged in with the Muscular Dystrophy Association, who can really help in terms of getting wheelchair. So the complications that may arise, for example, swallowing problems, as we've discussed. So it's often beneficial, I think, to have someone you can follow on a long-term basis.
Actually, Tom brings up a great point. Coming to clinic is not always just to see me. It's to see the ancillary staff that's there, the physical therapist, the ankle foot orthotic person. We've got a wheelchair person. We've got a dietitian. So it's not just seeing me. It's really seeing everybody else too.
Sure. Just one real quick question. Is IBM still considered an autoimmune disease?
All right, $1 million question, and we're gonna battle it out here probably. No. So I'll start. The genetics and the association with other autoimmune disease really does suggest that there is some sort of underlying autoimmune trigger. However, that said, the similarities that we see actually pathologically with neurodegenerative diseases and the refractoriness to any immunosuppressive therapy, in my mind, argues that even if the immune system triggers the disease, that actually something else happens later on that actually causes progression in the absence of the immune system. now. An alternative hypothesis is that the immune system has this just incredibly refractory T cells in the muscle, and none of the drugs that have been tried actually get rid of them. So it's really what I consider the key question in inclusion body myositis.
I agree. I mean, I think the fact that there's an autoantibody pushes me in one direction toward this being an autoimmune disorder. The fact that hereditary forms can look very similar pushes me in another direction. The fact that patients with HIV can have a presentation of inclusion body myositis in some patients that's exactly similar to sporadic IBM pushes me toward an immune therapy. My guess is that someday a therapy will have to tackle both arms. And so while I'd love to say it's one or the other, I think it really is probably both. And I think that ignoring one or the other is going to be something that'll get us in trouble in the future.
Okay, we're going to be down to our last two questions. Here's one right here.
Good morning, everyone. Good evening. I'm sorry, good afternoon. I have two questions for two special people that are from Chile and Argentina, Ana Maria and Hugo over there. So the questions would be this. For Ana Maria from Chile, she's had 20 years with lupus and 15 with IBM. The question is, are they related?
It's quite possible. So there are associations with autoimmune disorders and inclusion body myositis. It actually gets back to that earlier question about, is IBM an immune disorder? Well, there is a clear correlation that patients with IBM can have other associated autoimmune disorders.
Thank you so much. And for Hugo from Argentina, the question is, he's only had IBM a few years, and he only did a biopsy. He hasn't done anything else after that, nothing. What should he do next?
I'm sorry, he hasn't had a biopsy?
Just a biopsy. No medications, nothing of anything. What is the very next step to take?
So I want to make sure he has the diagnosis. So is that?
Yes, he has it, because in Argentina they don't have any knowledge regarding this illness. So what should he do in the U.S. or in Argentina now that he has the biopsy and it's confirmed that it's IBM? What is the very next step to take?
So there is no current medical therapy. There are exercise and things of that nature, making sure that other things don't happen. I advise that all patients make sure they don't fall, that they don't resist assistive devices if they need an assistive device. So, but as far as medical therapy, other than keeping healthy in all other ways, that's pretty much.
He wanted to know about maybe injections like steroids, prednisones, or anything like that.
I mean, without knowing, because
yeah. What I would recommend is at least once actually seeing a specialist in myositis.
Which type? I'm sorry. Which type of specialist?
So one of the members of the myositis medical advisory board, or another specialist with in myositis, because oftentimes actually even on muscle biopsy a diagnosis of inclusion body myositis is misdiagnosed. So one should see someone with expertise in that disease and make sure that all the clinical features fit, and one can also talk about other therapies and complications that might arise.
So I'm sorry, last question. What type of a doctor is this that actually specializes in this?
Either neurologist or rheumatologist.
Thank you so much for that. Thank you for your time.
Yes, my wife has IBM, and we all know that we need a great advocate, and you guys are two great advocates standing in front of us today. But the Myositis Association is even a great advocate that my wife and I have found out. And this year we received in the mail a book to give to our family doctor from the Myositis Association that is written for physicians. And we took it to our new PA that was in the family practice group we go to, and I told her that she had to read this book because 2 questions on our national boards would be in this book. Get her. And she shared it with the 2 family physicians, and it's a very great advocate for the physicians out there. Again, we're raising the awareness through this group here about myositis, and I think it's available. You can get a free copy from the TMA. If you did not receive a copy, I would highly recommend that. This had to be written by you guys, the physicians, because it's well written, and it's a medical journal for doctors is what it is. You can read it yourself, but it is really an education resource that our family physician, who actually, with my wife's liver functions being elevated one day in private, he asked me, "Is your wife a closet drinker?" And unfortunately, just did not realize that in myositis, the liver functions are elevated. They should have went the extra step. He really felt bad that it was missed in 3 years, as a lot of us have experienced. But this pamphlet put out by you guys in the TMA, get a copy for your family physician. It is very informative.
And thank you for talking about that. That is something that is available to every one of our members upon request. You can call or send an email to TMA, and they will send you out a copy of that. It's a great resource. And listen, we are so lucky, so blessed to have these doctors here today. Let's thank them. Good job. Thank you all very much for your questions. Good job. Good job.
Thank you.
Can I ask you one question? I went and I had a swallow test.
Good job. I was feeling bad. You were standing up that whole time. I was willing to.
I kept sitting down to give my legs a break, but I need to stand up because I've been sitting around for the whole conference. So.
Yeah.
We knew that was coming.
Yeah.
Get in line.
Maybe there are cards or something, sir, so that my friends can make an appointment.
Okay. In the book.
Yeah. Like which book? In that book that